Thank you for joining us for this episode of Mazars USA COVID-19 Healthcare Digest. Today I am joined by Colleen Matthews and Devin Judge of the Healthcare Consulting Practice, who will be talking about expanding provider services using telehealth during the COVID-19 pandemic.
Thank you, Jackie. And this is Colleen Matthews. And before we get started, I'd just like to recognize all the healthcare providers on the front lines for all the incredible and fearless work they are doing, and to all the support staff and volunteers at their side. Please stay well. Again, my name is Colleen Matthews, and what we're going to cover today is telehealth policies in the face of this COVID-19 pandemic. Obviously, primarily at the nationwide federal CMS level, as well as the state and local level. We're bucketing some of the considerations that providers should be thinking about and probably are already thinking about, but due to the rapidly changing nature of this emergency, always something to add to those lists. Our three buckets that we're focusing on are regulatory, contractual, and operational issues, and then we'll have some resources that you can tap into at the end of the presentation. So as far as COVID telehealth policy changes and considerations for providers, we know that the expansion of telehealth primarily started focusing at a CMS and due to COVID-19 testing and screening, but it became quite apparent fairly quickly that providers had to ramp up their telehealth capabilities to take care of the rest of their population, especially the chronically ill and those acutely ill who may not have COVID or weren't concerned about COVID-19 illness. So today we're going to discuss some of those policy changes, and as I mentioned, they are expanding at a rapid pace. We want to make sure that providers are thinking about certain things that really will help them not only recognize and ramp up their capabilities, but also make sure that they're being reimbursed for these telehealth services correctly. And then finally, again, COVID-19 has brought telehealth into the collective minds of governments, payers, and patients as a way to curtail the spread of the virus. But it's also going to give opportunities to providers and patients to think about the use of telehealth for this and even going forward. So I think this will be part of a long-term strategy going forward in population health in general. I'm going to pass it over now to Devin Judge, who's going to talk about some of the federal level changes.
Okay, so in order to accommodate the current COVID pandemic emergency, CMS and the federal government have made multiple changes to accommodate the needs of the existing pandemic. Federal government released the 1135 Waiver Coronavirus Preparedness and Response Supplemental Appropriations Act in order to expand telehealth services furnished to Medicare beneficiaries in any healthcare facility or their home beyond the previous rural restrictions. On March 17, 2020, CMS released additional policy changes to expand telehealth across all Medicare beneficiaries and waive cost-sharing amounts with healthcare providers and managed care MCOs. The Office for Civil Rights, OCR, at the U.S. Department of Health and Human Services has also announced that they are exercising discretion for HIPAA violations against healthcare providers that serve patients during the COVID public health emergency. And on March 30th, these policies were expanded to allow hospitals to bill for services provided outside their four walls, and to allow emergency services to also be leverage telehealth to determine the appropriate site of care and free emergency space for those who need it most. CMS has also added 80 additional services to be furnished via telehealth, and providers can bill for telehealth services at the same rate as in-person visits. In addition to CMS changes, at the federal level, the state governors have also released various directives in order to accommodate their specific state needs and Medicaid beneficiaries to reduce MCO copay barriers for patient evaluations, follow-up visits, medication refills, and testing for COVID-19. Medicaid will still require practices to follow the scope of their state practice acts, and which may limit telehealth services being furnished across state lines. While state and federal governments continue to work independently, to slow the spread of COVID-19, there are still many barriers that need to be adjusted to increase access for telehealth for commercial and other lines of business. It is highly recommended that providers validate their telehealth policy changes with their contracted MCOs in order to ensure that reimbursement protocols are understood and followed across their staff. That way they can be reimbursed appropriately. Due to the rapidly changing landscape of the pandemic, many federal and state agencies continue to frequently update their policies, and telehealth technology continues to be changed and accommodated in order to best serve the needs of the COVID pandemic. While this greater flexibility comes at allowing technologies such as FaceTime and Skype in order to perform telehealth services and waive certain HIPAA violations that previously had created a barrier for allowing the use of these technologies. In addition, there's been greater flexibility to allow new and existing patients in order to receive telehealth services, and discretion for the service. And the HSS has announced that there will be discretion for Medicare telehealth services in the extent that they will not audit whether or not there was an established relationship with their telehealth practitioner.
All right, before I get into contractual considerations, providers certainly probably are thinking there is Medicare and that they have their own regulations and rapid changes that they have been publishing, and then everybody else who they have contracts with. Certainly they can look at their Medicaid population as well that may have different policies and regulations. When we look at contractual considerations, some of the things that providers may want to consider is look at your current contracts. Do you have telehealth spelled out in your contracts with your current MCO contracts? And do you need to expand on that? Are you seeing more of a need for telehealth in your practice or at your place of service? Keep in mind that ongoing and open communications with your plans is going to be critical because a lot of these changes are going to be temporary in nature. Certainly some of these will become permanent in nature. I think this is going to cause a real reconsideration from both the provider and the health plan side to consider some of these changes as continuing forward rather than just temporary. If you look at some of the examples in that sidebar, you can see there's different policies and requirements from certain plans. And some of them are tied to dates, right? So they're going to have end dates, and some are tied, especially in the commercial plans, are tied to fully insured business. So there's going to be nuances within each telehealth policy and with each contracted payer. So some of the things that providers may want to consider, making sure your registration and patient accounting and clinical systems accurately reflect your health plan's health policies in order to decrease barriers to care. Again, right? Obviously, you're not going to be there collecting the cost-sharing amounts during a telehealth visit, but you want to make sure that the patients that the cost-sharing amount is being waived, that you're not billing those patients for those cost-sharing amounts. So making sure you're streamlining those processes. Keep in mind, too, that a lot of this started as coverage, telehealth coverage for COVID-19 only related services, and we do still see some of that in some plans. So make sure that you understand whether or not the telehealth services with your contracts are for COVID-19 related testing and services, or if they have expanded it to all their patient population. What product lines are included? We talk about a lot of Medicare, but what is the health plan that has, say, for example, Medicare Advantage patients in it? What are they doing to making sure that that some of the things that CMS is making available to its beneficiaries are being made available to the patients in a Medicare Advantage plan? Again, are these changes applicable only to fully insured, or will self-insured have the ability to opt in or out of these changes? And how do you identify them? And there's things you can do to identify those patients, but obviously on the back end, making sure that the explanation you're getting from payers is clear so you can understand what to apply a cost-sharing amount and when not to. And again, what changes are temporary, what is the end date for each, and will there be a retrospective process be needed to ensure proper reimbursement? Remember, this is new, uncharted territories for both the health plans and providers, and I absolutely would hope that both parties will be able to sit down and making sure they reconcile any issues that come up based on these new policies and this rapid expansion of telehealth. Operationally, again, while preparing for a substantial increase, or even if you're starting, but certainly a substantial increase in the use of telehealth, some initial studies have shown that it has been underused prior to this emergency. Providers should perform a capability assessment of staffing, processes, and technology to ensure access will be readily available. Some things to consider is when you're shifting from an in-person to virtual environment, do you need to redeploy or retrain staff or even hire new staff to have that capability available to patients? Upgrading or enhancing your video capabilities, as well as increasing the use of remote monitoring devices, especially for the chronically ill. Again, if we're having telehealth visits and patients who normally would come into the office to have their blood pressure checked or the weight checked, is there a need for you to expand your remote monitoring devices? Use of screening tools should be considered or enhanced, as well as any patient consent requirements. Probably those have been waived, but certainly using screening tools to evaluate whether or not a patient needs to be seen in person is called for. For CMS, I will turn that over to Devin right now.
To accommodate the use of telehealth services during the COVID outbreak, CMS has reduced many barriers, as we said in previous slides, to expand the use of telehealth services and reduce the risk of exposure for many providers. One of the ways that they've done this is by reducing the amount of originating and distant site restrictions, and have also provided guidance that actual office visits can be used during this time and billed in place of telehealth previous codes and services. CMS previously required telehealth visits to have real-time audio and video communication systems, which have been replaced since or allowed to be expanded with FaceTime, Skype, and other televideo platforms, as well as just telephone communications in general. Previous distance site restrictions that the provider needed to be in the office has also been waived for certain states. So make sure that you check with your local state policies for Medicaid beneficiaries to see what their latest policies are, as these are, again, frequently changing and new updates are frequently being added. During the last New York State Department of Health weekly healthcare provider update webinar, Dr. Marcus Friedrich, Chief Medical Officer and Office of Quality and Patient Safety, announced that providers would be allowed to bill telehealth services furnished from their own homes as a valid distance site, as opposed to in their office, which was the previous restriction here in the state of New York. So make sure that you continue to check your local state Department of Health websites for additional updates that may allow further expansion of telehealth services. CMS and MCOs such as United Healthcare have also issued new guidance allowing telephonic virtual check-in visits to be reimbursed with no visual technologies. Some other good resources to use and look to for guidance during this current COVID state of emergency for billing telehealth services is the CMS Toolkit. This graphic can be used as guidance in order to understand the best methods and protocols for billing the different types of telehealth services, such as telehealth visits, virtual check-ins, and e-visits, which are all allowed by Medicare. But again, as Colleen had mentioned, you should definitely look to your specific contracts and guidance provided by your managed care organizations to understand how there are specific reimbursement protocols and unique modifiers that they require.
And finally, here is a list of some of the latest updates. I'm sure there'll be more to come, but thank you for joining us today. And again, stay well, everyone.